Imagine you're sitting in a consultant interview. The panel asks you, a patient complains because they believe a consultant used AI to draft their complaint response. How would you deal with that? Now, that's a real interview question from a recent NHS consultant interview. And it's one of the 3 questions that we're going to dissect today. Welcome back to Beyond CCT. My name is Dr. Pranav Kukreja. I am a consultant anesthetist and I sit in on a lot of consultant interviews, and I'm here to help you guide you through your consultant interview. Now, last week we spoke at length about Ben's pre-interview experience, where he was asked to chair a meeting and to respond to a complaint letter. And I had said that in this episode, we'll go through some of the questions that he got asked, along with the presentation that he was asked to make. So for this episode, let's just focus on the 3 most interesting questions that I think will be extremely useful for you to learn about. Now, what I said about AI earlier, AI is becoming increasingly something that is everywhere around us. And this discussion around AI in the NHS, they're still confined to the planning stage, in that, you have colleagues in your department who talk about it in their daily use scenarios, perhaps editing stuff or making presentations, doing a bit of background research, and so on and so forth. But when you get asked a question like that in an interview, where the panel are saying that they had a patient who made a complaint and has received a response from the trust, who the patient thinks that the response was written by AI, they're unhappy with it, the panel's asking you, how do you deal with that kind of situation? Now, in my view, there are 2 aspects to this. First is, what's your personal view on it? And second, what, if any, is the official stance about this sort of thing, about AI? So let's first look at what the official status of AI is. So first of all, there isn't a single document called How Doctors Should Use AI. Instead, there's the guidance from the usual bodies, the GMC, NHS England. We'll go through some of these now. And they all look at AI from a slightly different perspective, because all of these organizations have their own purposes in the first place. So let's start with NHS England. NHS England is largely quite positive about AI. It doesn't say don't use AI. It actually says quite the opposite. It says that AI has the potential to improve productivity, reduce administrative burden, and support clinical care. Now, you may be asked to comment on an article which exists somewhere which says that AI can help reduce the administrative burden for managers mostly, and some clinicians, by a ridiculous number, something like 35-40%. Now, there's pros and cons of those type of arguments as well. But basically, what NHS England is saying is that it can contribute to the reduction of administrative burden. It goes on to say that it is a supportive thing. It's not a like-for-like replacement, and that clinical judgment still has to prevail. The final decision, if AI is used for any clinical situation, still rests with the clinician, and AI can assist you, but it doesn't take away the accountability from you. So that's quite important to remember. The second thing that NHS England say is about information governance and patient confidentiality. So all of those things around patient confidentiality, where the patient's information is confidential, should only be used for the purposes that it is designed to be used for. It should be kept strictly within the domains of a secure environment. You cannot be breaching any of those if you're using AI. So identifiable patient information should only be used within approved systems that meet the NHS information governance requirements. Public AI tools, things like ChatGPT, other clinical diagnostic apps, unless your organization has approved them and has appropriate safeguards in place, you should not be using them. Clinicians' output, the clinical output, again, responsibility sits with the clinician. Now, the big thing here is what NHS England say is that if you're using an AI tool or any AI app, you should stay within the rules of your organization's policy on AI. Now, the big question again here is, does your organization have a policy on AI? Because it is so new and we all know the pace of things. It may be possible that your organization does not even have a policy on AI yet. And that is something you can catch on to, where you can, if you are interested in that sort of thing, it's something that you can definitely develop in the future for the organization, and you can probably sell it as a selling point if it is one of your strengths. Anyway, moving on to the GMC. The GMC talks about similar stuff about accountability in patient's care. It rests with you regardless of whether AI was used or not. The MHRA looks at it from a slightly different angle, in that MHRA, it doesn't focus on the clinicians, it focuses on the products that function as medical devices. So if you're using AI, if your AI tool is interpreting CT scans or ECGs or providing any kind of clinical decision support, it will need to meet the same regulatory standards as any other medical devices that the MHRA would use. That provides assurance that products have been appropriately evaluated before they reach clinical practice. And finally, there's the Information Commissioner's Office, or ICO, and their focus is on information governance, making sure that all the data complies with UK GDPR principles, transparent about how the data is used and that sort of thing. And finally is NICE. NICE doesn't regulate AI directly. It asks the evidence question. Does the technology actually improve outcomes? Is it safe? So it would look at the evidence that exists out there for, like NICE does for any new medicines or any new technology, and it asks the question of whether there is good quality evidence to justify adopting that AI technology within the organization. So overall, the message, interestingly, is that all of these organizations are broadly saying the same thing. None of them are anti-AI. In fact, they encourage AI, but encourage it with responsibility. They all emphasize on information governance, on transparency and professional accountability. What I also found interesting is that the guidance doesn't really cover some aspects where, there's very little detail about using large language models such as ChatGPT, Claude, or Gemini for everyday professional tasks, like drafting clinic letters, preparing complaint responses, or writing reports. Now, these conversations are happening all across the NHS every day, and I think the national guidance is still evolving. So in light of that, coming back to the question that Ben got asked about the fact that the patient isn't happy because they think AI was used to answer it, I think the first thing to ask is, what exactly is it that the patient is unhappy with? Because if they're unhappy with the fact that AI was used to draft the letter, but their details were anonymized in such a way that it is in keeping with the hospital policy and in keeping with GDPR, then that's fine. You just have to tell the patient that AI was used to maybe refine the answer, and yeah, it was used, because you have to be open and transparent with them about telling patients that AI was used. Now, on the flip side, if the AI was used in such a way where data breach occurred and the patient's confidentiality, it left your departmental governance systems and went out into the big wide world, and you got AI to sort of process that information and come back with some sort of a response, then there's a bit of a problem. But then you shift your focus on to the openness and transparency with the patient. You don't hide that anymore. You apologize to the patient, explaining what happened. Maybe the remedial things you could do in the organization is to start working on having a uniform policy across your organization for situations like this and for information within the department. And then latching on to that, if that did happen, like I was saying earlier, you can then start working on the policy, look around for evidence, speak to outside stakeholders, see what's going on in the department. I'm sure someone somewhere is interested in it, and start to develop a local policy for the use of AI. Because let's face it, that AI has tons of advantages. You no longer exist in a world where you say that, oh, no, we shouldn't be using AI, because even universities are now starting to say that, well, use it, but use it as a research tool, use it as a tool to brainstorm with, but don't let it do your job for you. So I think that should form the basis of most of your answer for this question. I'll put in some links to the documents I spoke about earlier in the show notes down below. Moving on to the second interesting question that I think it's worth talking about. This was a question which kind of bordered around clinical judgment and conflict. Ben was given a clinical scenario where, as I've said before, this was for an ICU consultant interview. So you're the ICU consultant on call and a patient presents with acute bowel ischemia, is very, very septic, critically unwell. The surgeons wish to admit the patient to ICU and operate the following day. And the question they asked was, how would you manage this situation? Now here, the panel's trying to test a number of things. You could argue that they're trying to figure out if you say that, clearly the point here was it's a sick patient who needs a laparotomy. Are you able to make your point that that's what's needed and not give in to surgeons who want to do the operation the next day? And they're kind of seeing if you can own the responsibility. Can you deal with it on your own or not? And do you provide them with a defensive answer? You can escalate it to the clinical director or medical director, but that has to be the last thing that you do after you've tried to resolve the issue yourself. Now, in going about answering a question like this, there are potentially a lot of things to discuss. So you would speak to the surgeon yourself, find out the reasons behind the decision to operate the next day, because as we all know, such a septic patient is probably better off going into theatre straight away with ongoing resuscitation, or maybe a bit of resuscitation prior to induction in the anesthetic room, rather than being left in ICU overnight, because more often than not, that's going to have a disastrous outcome. So being proactive in having those discussions directly one-to-one with the surgical consultant, if required, seeking a second opinion from somebody else in the organization. It could be the anesthetic consultant on call if you are the ICU consultant on call. Emphasizing the fact that this isn't a confrontation, but you're going to have to negotiate your way out of this. Try and influence it rather than simply escalate it higher up. You can quote guidelines and sepsis 6, but it's not a registrar interview. You are not expected to be answering what sepsis 6 involves. You can probably quote it to say that, well, yes, sepsis 6 have all the things been done. And then there's other things such as adopting an MDT approach to it, bringing everyone in together. The ICU consultant, general surgeon, anesthetic consultant, theatre coordinator. The aim will be to build consensus, remove the delays, agree the safest plans, exploring the barriers for not doing the operation that day and putting it off to the next day. Don't assume disagreement is purely clinical. There could be other possible reasons why the surgeon may not want to do the operation. They could be someone who is risk averse. They could be towards the end of their shift. They could be a brand new consultant like you and might just feel quite pressured into doing that operation. There could be other pressures, any kind of pressures. So you'd say that you'd try and identify them and remove those pressures. Now, this candidate had mentioned something about all of these things, the fact that they try and negotiate with the surgeon, use factual information, look at the deteriorating condition of the patient, have a conversation with the surgeons, try and convince them, etc. And if that didn't work out, they would escalate it to the clinical director or to the medical director. And the follow-up question here was quite interesting. They said, apart from escalating concerns, what else could you do about it? And I think what they were trying to hint at here was speaking to other people, the kind of things that I said earlier, the MDT discussion. So it might well be a case of the medics speaking first. So the surgical consultant, surgical reg, anesthetic consultant, ICU consultant, maybe one or two registrars from anesthetics and ICU who would, at ST 6 and 7 are fairly experienced. Along with these, the nursing staff, the emergency theatre coordinator, and all this while ensuring continued optimization of the patient with the view to take the patient into theatre. Now, it might well be that that is definitely not the right thing to do, but you'll find out during the course of that. It brings me to a very important point about negotiations here, where it's the sort of thing that we never get told about or taught about. It's a skill that can be developed. And I've said this about many, many things, that there are so many skills that we are not even told about, and we don't register it ourselves because we're just oblivious to it. And in the process of doing these things over the past of being clinical director for the past 2 years or so, I've come across some very good reading material, which I highly, highly recommend that you read up as well. And I'll put a link down below to this book called Never Split the Difference, which is written by a guy called Chris Voss. Voss is a former FBI hostage negotiator, and if you don't want to read the whole book, you can read it on Audible if you like. Listen to it on Audible rather. If you don't want to listen to the whole book, at least start by listening to his TED Talk, which I'll put the link to down below. The final question from this consultant interview was very different. It wasn't about managing a sick patient or handling a complaint. Instead, it explored whether the candidate understood the wider challenges facing the NHS. The panel went on and asked whether the candidate was familiar with, in fact, they didn't name it, they referred to the RCoA's State of the Nation Workforce Report, which came out about 2 or 3 months ago. And it followed a nationwide survey done to look at how departments were staffed, whether they had any training places left, and that sort of thing. Now, interestingly, the candidate hadn't read it. So don't panic if you're that candidate and this happens to you. Many candidates wouldn't have read every national report. And the panel they're not out there to catch you out. And if you haven't read it, well, say you haven't read it, but you kind of know about it, and they're just looking to see whether you understand the problems facing the specialty and whether you think like a future consultant, as I've said before. One way I like to think about this report is that it answers 3 very simple questions. Where are we now? Why did we get there? And what should we or what can we do about it? If you can structure your answers around those 3 headings, you'll already sound organized and strategic. So where are we now? First of all, this report says that the UK is currently short of about 2,250 anaesthetists, which makes up 16% of a workforce gap. And although consultant numbers have increased, they aren't increasing fast enough to keep up with the rising demand. So the waiting lists remain high, operating lists are cancelled, and perhaps most importantly, the report highlights increasing evidence that workforce shortages are affecting patient care. Now, both are increasing. We've said the workforce numbers are increasing, but the demand is increasing as well. So why is the demand increasing? It's good to be able to objectively state why it's increasing. And some of the reasons are things like there are now older patients. There's an increasing prevalence of patients living with obesity. The medical comorbidities have gone up way more than they used to be several years ago. The operations themselves are becoming increasingly complex. Emergency work continues to grow. And anaesthetists are now involved in many, many more areas than simply providing anesthesia in theatre. And perioperative care is a prime example. Perioperative care, by that I mean perioperative medicine, pre-op assessments, hospital-wide emergency responses, procedural sedation. There's a wider and wider involvement of anaesthetists across the whole hospital. But demand is only one side of the equation. The report also discusses why supply hasn't kept up. Now, one of the most interesting points it makes is that many hospitals actually have the educational capacity to train more anaesthetists. The limiting factor isn't necessarily trainers or training places, it's the funding. Now, I know this firsthand because I had responded to this report when they sent it out to all clinical directors in the country to ask, have you got any training posts in your department or any potential training posts in your department? And I remember saying yes to it. And I think they've come out with something like about 800 posts in the country are available, but there isn't the matched up funding from deaneries, and yes, they will have their own reasons. I'm not blaming the deaneries for this. They will have their own reasons, but there's that mismatch. That's one of the reasons why you see more and more people building portfolio careers these days, where people don't get into a training rotation straight away, and the college has actually relaxed its attitude towards those who are not in training rotations. So, for example, as long as you've got your competencies in the things that you're supposed to get them in, it doesn't matter whether you got them in a training numbered post or you didn't. So, coming back to the report then, so there was also a bit of blurb on experienced clinicians leaving the workforce earlier than expected, and these reasons are also well known, is things like burnout, stress, pension taxation, pay, administrative burden, poor IT systems, poor working conditions, increasing sickness and absence, and career progression even. They are of relevance to us as individuals, because the others, things like pension taxes and pay, that's beyond your control or my control. But we'll come back to these reasons in a bit when we look at the actual question. So what does the college recommend we do? They're fairly predictable, but there are important ones. There are the national ones: increase funding for training posts, improve workforce planning, retain experienced clinicians by improving all of those factors we listed out, reduce the bureaucracy, invest in better IT systems, etc., etc. So, these are the sort of things that some of them are beyond our control. But here comes the follow-up question, which I think is more interesting, which was, what can you do about that problem? So they asked this candidate specifically about staff retention in that particular hospital, because they'd been a resident doctor there before, they'd gone away, and now they'd come back and applied as a consultant and said, well, you know about what goes on here. What do you think you can do to increase retention? And that's where many candidates drift into talking about national politics. Personally, I wouldn't. It would sound like a very fluffy answer, but as an individual consultant, you can do certain things within your department, and that might include things like improving the departmental culture. I've always said that things like stress, burnout are far less likely if, when I'm turning up to work, I'm looking forward to it. I'm not worried about coming to work. If I actually like coming to work and I enjoy working with the people I work with, it's less likely that I get burnt out from working. So that's the sort of thing which I think you can say you can influence within your department. So improving the departmental culture, creating a supportive environment for trainees, unnecessary administrative frictions. Yeah, that can be argued as something difficult, but once you are fairly embedded into the department, there's things that you can ensure a smooth flow of patients, and thereby improving the user experience for yourselves and your colleagues. So unnecessary frustrations so things like pre-op assessments, the flow of patients across theatres. These are the sort of things that they are slow, but they are within your gift to improve. So at least in an interview, you can say those sort of things, and they sound more credible than saying that, well, there's not much to do other than negotiating with the government about pay. So that's the sort of thing which, there's a few more examples. Mentorship, looking after colleagues following difficult cases, small improvements that make everyday work less stressful. That's the sort of thing which makes people feel valued and makes the culture come across as more positive. The panel then personalized this question, like I said, to a resident workforce at that particular hospital. And again, I'd avoid going into criticism of working patterns for residents or any other group of staff. You can drop in things about the understanding, if they ask you locally how you come across or how you see that organization as. You can talk about things like the workforce mix, the recognition and importance of supporting SAS doctors, locally employed doctors, residents, consultants. There has to be some degree of equality in how they are treated and making everybody feel welcome. So that's that for this episode. I will continue to try and bring you more and more content on consultant interviews. In fact, The next few episodes, or at least the next episode I'm planning on, is to do with non-consultant interviews, so into senior clinical fellow jobs, and maybe there's something for SAS doctors as well coming up soon. But as I've said before, I'm very, very new. Any feedback from anyone is really, really welcome. So please leave me a like, or leave me a rating, or leave me a comment, or reach out to me at atracurium@gmail.com. Yes, that paralyzing drug, atracurium. All the best, and I will see you next time. Bye bye.